Thank you so much, Mr. Chairman, for this very kind introduction. I wish first to thank George and Antonios for this very kind invitation and for hosting us so well. So, indeed, in the next 25 minutes, I will try to review with you what should be the dose of CRT in septic AKI in 2012. And indeed, if we go a bit backward, let's say before the year 2000, and we were in an ICU, and we had, let's say, a small lady of 45 kilo needing CRT, and a big chap of 120 kilo on the other side. And we were doing CRT just the same way, exchanging perhaps 1 liter of 1 liter and a half, but just ignoring the difference in body weight. And I think CRT is a bit like any type of treatment in ICU, and we should adapt the dose to the body weight of the patient. At least it makes sense. And so, it may be the right moment also to speak about this because, you know, there has been a lot of ongoing and completed study in the last decade from 2000 to now, and some really big difference in the trial. So, okay, first thing maybe I have to address is really rationale. Whenever we are applying CRT for sepsis, do we know really what we are doing? Not sure about this. How can we increase removal, increasing volume, porosity, other adsorption perhaps? Should we target, big question, SIRS or CARS or both? Let's see. Then the most recent positive study on CRT, randomized controlled trial, and obviously, very important, the negative ones, quite a lot in the recent years. Some view of the future, and then about the study that we complete by our group in conclusion, obviously. So, whenever we are thinking we should do some CRT, we think we will plugging a large bore catheter here in the central venous system, and we think, well, we are doing the job if we can remove some mediator here. But you know better than I do that the battle is taking place in another compartment, the capillary side compartment, when there is some endothelial disruption. And to complicate the issue, obviously, these two compartments are far different, at least in size, 30 square meter from this one, central venous system, and the capillary compartment, tenfold greater. To complicate even more, the interaction between those two compartments are really, really difficult to understand. Nevertheless, if we go further and we say, well, I have a pretty good method to try to remove mediator from the central circulation, 40%. That's great. What's going to happen to this capillary compartment if we believe there will be some passive transport? Well, because this one is tenfold greater, it's going to be 4%. Oh my God. Maybe this is not going very helpful for treating our patient, if it's going anyway. So, in the summer 2005, the group of Stephen Alexander from the Stanford University did put forward a very nice hypothesis based on animal data and some clinical data, showing that whenever you were exchanging volume as you have volume of 3 to 4 liters per hour, there was a third player coming into play, the lymphatic circulation, which is also, in some way, linking the capillary side compartment back to the central venous circulation. And they were able to show, especially in the animal data, that whenever they were exchanging this, they were able to have an active transportation this time through the lymphatic circulation back to the central venous circulation and increasing mediator and cytokine by 80-fold. So, nice hypothesis, but obviously we should need some more data on this, and especially some more study. And currently we are doing some more on nuclear imaging study to try if we can reproduce this in a human setting only. Anyway, so should we target SIRS or immunoparalysis or both? You know this better than I do. Whenever you have a septic insult, you have a boost of pro-inflammatory mediator and then anti-inflammatory mediator. And so people say, well, stop, do not remove anti-inflammatory mediator, you may kill the patient. Here, you see already that both are mostly intricated, so the new terms came about. MARS, mixed anti-inflammatory response syndrome. Anyway, some interesting evidence coming from a nice study from John Callum looking at community-acquired pneumonia and then specifically looking at those where we're going into severe sepsis and then assessing the pro and anti-inflammatory pattern by evaluating IL-6 and IL-10. You tell me IL-6, 50% of the patients, of the people should say, well, it's pro and anti. Anyway, and whenever doing this, obviously, needless to say that where they were looking to the high patient with high level of pro and anti, the likelihood to die was very big. Okay. Needless to say that whenever it was low, the likelihood to die was very small. More complicated case, this one here. Embarrassing, I guess, because this one has a low pro-inflammatory mediator load, high anti-inflammatory mediator load, so maybe you should not touch on this one. And he was able to show that a lot of patients with this pattern went to this pattern, low, medium, and even low, and so exhibiting lower risk of likelihood of dying. So saying that it's not really the true balance, but really the levels which are extremely important in this. Anyway, doesn't seem to like that anti and pro is making the difference. So now starting with the positive randomized study regarding CRT dose in ICU. So, the seminal study of Claudio Ronco, published in The Lancet 2001, 25 patients randomized into 3 groups, 20 ml per kg per hour, 35 ml per kg per hour, and 45 ml per kg per hour, and then assessing survival rate. And as you can see here on the graph in green box, you see that you had an increment at the rate of 35 of nearly 20%, which is obviously enormous. And there was then a kind of plateau when you went to 45. So the study was positive and saying, well, although it's a monocentric study, and saying we should now use a dose of 35 ml per kg per hour. Already, they were looking as a post-hoc analysis to the sepsis subgroup in blue bars and showing that in the septic AKI group, the dose which was able to increase survival was not 35 but 45. But post-hoc analysis, small group of patients, septic, and so no statistical significance. only fueling further study to see if we should have a higher dose in the septic AKI group. So, just a few years later, a group of Geneva, led by Patrick Sodan in the University of Geneva, was doing the same kind of study, and this time enrolling 200 patients in two groups. First group, CVVH at 25, so roughly the control arm, let's say, of the Ronco study, comparing to, let's say, more or less 35 ml per kg per hour group, but having some diffusion plus some convection plus diffusion. And you know, convection is thought to be better to eliminate middle and large molecules, including mediator. Nevertheless, they were able to show a significant increase, again, of nearly 20% in survival rate at day 28. And at this time, with this paper in Kidney International in 2006, we had two level 1 study. And so it was some kind of grade A recommendation to say we should stick on the 35 ml per kg per hour rule. Obviously, this was not standing for some long time, but before going to this, it's probably worth mentioning this study here, done by the group of Helmut Schöffel in the Munich University, this time assessing intermittent hemodialysis in two ways. First way, classical one, so 3 times a week, like we do from chronic dialysis patient, 3 times a week like we do for classical chronic dialysis patient, or daily hemodialysis. And showing striking result, again, an increment in survival, although a bit odd survival rate 40 days after the last session of HD anyway. But saying that probably if we have to use at some stage, and I will come back to this, intermittent hemodialysis in our ICU patient, we should not stick to the dose of the chronic patient. Our acute patients are very different, and they may probably need daily hemodialysis instead of 3 times a week. So, time to go to the negative trial. And the first one came in 2008 in the New England Journal of Medicine, a great undertaking done by the group of Paul Palevsky in Pittsburgh University, randomizing nearly 1,200 patients. And there was two, let's say, side of the study. One side, small one, with hemodynamically stable patient. I will not speak about this, but the large one was this one. With unstable hemodynamics, randomized into two groups, reproducing, in fact, the Ronco study. So 20 mLs, but divide in two, diffusion and convection, so maybe not ideal, and pre-dilution, even worse. And then another group, 35. And as you can see, survival rate at day 60 was nearly exactly the same, and no statistical difference. But there was some comment after this release of this study, and one of the comments was to say, well, it's not pure convection, so you are not able to remove middle and large molecule. But more intriguing was the issue of timing. So in their study, perhaps because of the open ICU unit in the US, the mean delay between ICU admission and start of the therapy was 7 days. Whereas if you compare with Australia, Canada, Europe, many countries, most of the time less than 3 days, even less than 2 days. So some concern if the delay was too long to see if we could still reverse this situation. And even more striking, problem, shortcoming, if I may say, in this study was that the attending physician became nervous in this study because they had patients with hyperkalemia, metabolic acidosis, hypervolemia, and they were asking the PI, Paul Palevsky, can we do something about it before the randomization? He said, well, you can indeed. You should do to those patients who requires, on decision on the attending physician, either an intermittent hemodialysis or a SLED procedure. So it turns out that more than 67% of those patients had an initial, some way, intermittent therapy before entering the study. So fueling the idea that this may be some kind of bias. Anyway, still a great undertaking with so many patients included, and it's a negative study, obviously. So, going a bit further, still reviewing negative study, the study done by Didier Poya and Larry Bourzier in Paris. This study was, let's say, constructed, before 2000, so before the study of Ronco was published. And the idea of the Poya was to say, well, we should do a prospective randomized study assessing the utility of CVVH in septic shock before AKI has occurred. So they went on to randomize 80 patients, 40 in each group, classical treatment and versus classical treatment plus CVVH, regardless of the body weight. Didn't know about the Ronco study, so exchanging 2 liters per hour, regardless of the body weight of a patient. As you can see here, when they were looking at the course of the 2 group, plain line hemofiltration group and dotted line control group, well, it's a bit frightening because the hemofiltration group is going worse, although not attaining significant difference value in terms of mortality, neither in SOFA score, but saying that perhaps we should not use CVVH in septic shock without any signs of AKI. And going back to the dose, according to the mean body weight of the patient in the study, it was around 25 ml. Now, obviously, the gold stone of the study, the one launched by Jenzik and by Rinaldo Bellomo, published in the New England 2009, the renal trial, 1,500 patients included in 2 groups, again trying to mimicking the study of Claudio Ronco, so 40 mLs versus 25 mLs, and then assessing mortality 28 days, 90 days. Well, 2 small comments to say that, again, the dose was split into 50% diffusion convection, maybe not ideal, and then the study was not designated for septic AKI. It was really global AKI, including, obviously, a sepsis subgroup. And as you can see here, the Kaplan-Meier curve, the 2 groups are completely identical in terms of mortality at 28 and 90 days. No difference at all. And this time, timing was really short between ICU admission and start of the therapy. So, after this study was published, obviously, the thing has changed to say, well, in global AKI, at least of non-septic AKI, we should not go over a dose of 25 ml per kg per hour. So, to give a bit of a sense of what could be the future if all those studies will be negative, maybe we should move on to new membrane. So this is the classical membrane we are using nowadays, cutoff of 35,000 Dalton. And maybe we should move to a large pore membrane, 60,000 Dalton. I showed a picture because you can see the holes are not very homogeneous. You have holes of 30,000, 100,000. In some way, you can lose albumin. So whenever you are using this membrane, although the nominal cutoff is 60,000, you have to assess safety. Are you losing albumin by doing this? So we went on to review this very nice study from the group of Bellomo, assessing this membrane in the usual fashion, CVVH, with a rate of 2.5 liters per hour, using a standard membrane and evaluating convection rate of IL-6. And I show you the sieving coefficient. When it's 0, nothing is going across the membrane. When it's 1, everything is going across the membrane. And as you can see, striking difference when you do a classical membrane. It's nearly nothing that you go through the membrane, and when you got a high cutoff membrane, it's 40-fold what you get, even after, in light blue here, 24 hours. So, looking promising. So, went on to do a study in clinical condition called a high-cost study for high cutoff sepsis study, multi-center study evaluating a high cutoff membrane. And the primary objective was a reduction of catecholamine requirement in the high cutoff group. And the study was powered to show 50% reduction in catecholamine use with 120 patients, 5D treatment in CVVHD. I will come back to this. And two major goals. So, is this effective? And is it safe regarding albumin losses? So, effectiveness. Unfortunately, once more time, the study was completely negative regarding the primary endpoint, so need of norepinephrine, although some slight decrease in the high cutoff group here in orange, but this is absolutely not statistically significant. Secondary endpoint, they on ventilation, exactly the same picture. Need of CRT, exactly the same. Although not a secondary endpoint, they were looking at mortality at 20 days, exactly the same. The only positive thing that came out was this one here, saying that this membrane is quite homogeneous because we haven't lose more albumin in the high cutoff group in orange as compared to dark blue. And so, this study is negative regarding effectiveness. This is due to the technique, CVVHD, so continuous hemodialysis, cut off 5,000 Dalton, not very much. Might be, if we look at this study of, again, the group of Rinaldo, this table here, using CVH at 20 mils, plus high cutoff membrane, you see not that much you can remove of mediator. Whenever you are coupling high cutoff plus a higher dose, 80 ml, oh gosh, it's not an additive effect. 1 plus 1 is not equal to 2, but nearly equal to 40, so you have a synergistic effect. So the conclusion should be that we should reproduce another high-cost study using this time a CVH mode and maybe not too far from this dose. So moving to the last series of slides about the Ivory study that we did in our group with Olivier Johannes-Boyot from the University of Bordeaux, randomizing 140 patients in septic shock and acute kidney injury. And the interesting thing here was that we started at not at the rifle failure score, the usual score, but rifle injury. Randomization was computerized within 24 hours, and two groups reproducing in some way the subset of the Ronco study regarding septic AKI, 35 versus a higher dose, and we choose 70 ml per kg. Primary endpoint, 28-day mortality. Secondary endpoint, 90-day mortality. This is the flow diagram, classical one, 170 roughly patient assessed, and then 140 randomized, some exclusion, and left with roughly 70 patients in each group. So just to emphasize that we were starting at the rifle injury, so creatinine 2/4 or oliguria less than 0.5 ml per kg per hour. So, because the paper is submitted, I cannot show you the two Kaplan-Meier curve, but I will show you how here. The two groups are exactly the same, finishing at 90 days, 52% of mortality. So, study completely negative. No difference in the two groups when you compare 35 versus 70. So, but perhaps interesting to say is the global mortality for those patients in septic shock plus AKI plus multi-organ failure at 90 days was 52%. So, is it bad? Is it good? Obviously, it's not a primary endpoint. We have to be very cautious. And when we compare with other large studies, like the Hemodive study done by Christophe Vincenot in Paris, published in the Lancet, comparing CRT intermittent, they had a higher mortality rate at 90 days, although having the same SAP2 score and having less patients in shock. But you say it's old stuff, so if we compare with more recent nice study, the Etienne study from Palevsky, and comparing similar groups, so far cardiovascular score of 3 and 4, and sepsis patient, we've got 60% mortality at 60 days, which is greater than here, and knowing that we have only half in the septic subgroup we are in shock. So, but obviously we need to compare with the gold standard, the Reynolds study. And the Reynolds study, if we compare again, similar group, so for cardiovascular score of 3 and 4, and sepsis subgroup, we end up with 50%, very similar. But we have to say that half of the patients in the stage 3 and 4 are only in sepsis, and we know septic AKI has a worse prognosis, and more importantly, in the group of sepsis, only half were in shock because the inclusion criteria was severe sepsis and not septic shock. So maybe this difference, but this is obviously speculation, is due to the fact that those three studies were starting at the failure stage and we were starting at the injury, but it's not a primary endpoint and we remain extremely cautious. Last slide before the conclusion. Worth to note that the DOREMI study, standing for dose response in a multi-center trial, was assessing in a cross-sectional study throughout Europe, including 900 patients nearly, whenever outside a prospective randomized study, is there a difference between the prescribed dose that you want to give to the patient at the time 35 versus the truly delivered dose to the patient because of stopping the therapy to go to the CT scan, to the theater, or whatever, and of clotting. And you see that there was a difference, significant difference between the prescribed versus delivered dose of about 7 ml per kg per hour. So maybe we should have this in mind whenever we prescribe a dose. So, the chairman, if I may now try to give some take-home message, I would have to say that indeed the CRT dose in non-septic AKI should be 25 ml per kg per hour, but as delivered dose, not as prescribed dose. So maybe you have to prescribe 30 to get there. In septic AKI, so far, with the Ivory study, we do believe that 35 is really enough as delivered dose. Now, more importantly, and maybe the most important thing I want to say in this talk, is the aggregation they did about the Etienne study and the Reynolds study by Rinaldo Bellomo and John Prohl, published in Nature Nephrology Review in 2010, and showing that whenever a patient was hemodynamically unstable and in AKI, whenever you start with intermittent therapy, he had 50% more chance to be dialysis dependent and to remain in chronic dialysis. So it was really written in stone in this paper that whenever a patient is hemodynamically unstable with AKI in the ICU, you should really privilege CRT, not for mortality but for morbidity. So dialysis dependencies and risk of chronic renal dialysis. So far, we have 5 large randomized trial negative regarding dose. ATN, renal, Ivory, a study also from the US done by Ashita Tolwani, published in GISN in 2008, and just 2 weeks ago, a study coming from China evaluating 180 patients, severe sepsis 2 group, 50 versus 75, also completely negative, with a quite high mortality rate. So we should move to something else. And maybe the next approach would be new membrane, including high porosity, although the first study, ICOS, was negative, and maybe also high adsorptive membrane. And so just to finish off, Ivory was negative in the primary endpoint, but maybe the early start of the rifle score was maybe responsible, maybe, for the lower mortality at 90 days. Thank you so much for your kind attention.